Hi, my name is Angie Staley-Capel and I am in the RN to BSN program at Winston-Salem State University. And this is the video for health assessment and examination. This is Mr. Paul Davis. He is here to help me today. And Mr. Davis, is it all right with you if we videotape you for this final examination?
Yes.
Thank you. To get started, I'm going to go wash my hands.
Okay.
In order to begin, I have pulled up your electronic medical record here in our system, and I have overlooked your health history and your family history. Have there been any changes to your health history since the last time you were seen by one of our doctors here?
No changes.
Any changes to your family history? I do see where your parents both have some type of cardiac history.
No problems.
What about your brother? Is he doing all right?
He's fine.
Well, good. I do have to ask you about, do you drink alcohol?
No.
Smoke?
No, I don't.
Do you dip?
No.
What about any street drugs, illicit drugs, anything like that?
No.
All right, well that's good. I do want to ask you, have you been having any chest pain, tightness, pressure, anything along those lines?
No.
No? This is just a follow-up visit for you today?
It is.
Well, good. But if we should ever have any chest pain, we do want to know if it was brought on by exertion, such as being out in the cold, an emotional stress. Sexual intercourse can bring on some types of chest pain. Also smoking and big meals. But if this chest pain is relieved by rest, sometimes it is indicative of angina. But if we were to have any chest pain like that, we could try some nitro tabs that go under your tongue. And if it was relieved with that or by rest, that would be more indicative of that type of chest pain. Also, do you ever get dizzy or lightheaded?
No.
Well, good. Do you ever get short of breath?
No.
Well, if you ever did get short of breath, I would need you to call me and let me know. I would like to know whether if that type of shortness of breath came from an activity, what you were doing when it happened. Did it come or go when it happened? Did it come on suddenly? Were you doing something at that time when it came on? Does it ever wake you up at night? I would need to know that, because if it should happen to happen, it's called paroxysmal nocturnal dyspnea, which means that when you lay down at night, being in recumbent position, you're getting a lot of extra blood flow to the heart, and it's indicative with congestive heart failure. And when you're laying back like that, all that blood volume at one time can make you feel like you need to sit up real fast and gasp for breath. I would need to know something about that, okay?
All right.
Also, do you ever have a cough, any persistent type cough, productive cough, anything like that?
No, I don't.
Good. Do you ever get tired easy?
No.
All right, but if you should ever get tired really suddenly or anything, I would like to know about it. So yes, I would like for you to call us and let us know if anything like that should happen. I would also like to know, did it start suddenly? What were you doing when you got real tired? Do you get more tired in the morning, or do you get more tired in the evening? Stuff like that. If you get tired more in the evening, it is more conducive toward the heart, as where if you were more tired in the morning or everything, which is more leading toward anxiety or depression. Those two types of things kind of go on all day. Whereas the shortness of breath or all that, or the tiredness, is going to come on at night. Okay?
All right.
Also, do you ever swell? Do you get any edema in your feet or legs?
No, I don't.
What about in your hands? Do you ever feel like you get any swelling in your hands?
No.
Good. Do you ever notice if your fingertips or if you look at your mouth sometimes, if it should ever turn blue?
No.
Good. Those things would mean, if it should happen, that there's less oxygen getting towards your extremities and it's going to turn a little bluish color. That's telling us that we need to see you. So if that should ever happen, please call and we'll make you an appointment so we can come in and see you. Also, if it was related to cardiac issues, the swelling and everything is going to be more prevalent in the evening, okay?
Right.
As opposed to the morning, because you've been laying down all night, legs up, so therefore the edema is not going to be as bad, okay? Also, do you ever have frequent going to the restroom at night? It's called nocturia.
No. I might get up once.
All right, well that's good, because sometimes with heart issues, heart problems, you know, being with the edema and the swelling, everything, it is going to start bringing more water and everything to the kidneys, and that's going to make you go to the bathroom more at night. So just be aware of that, okay?
All right.
Also, is it all right if I touch you?
Sure.
Or can I look at your neck?
Mm-hmm.
So what we're going to do is I'm just going to look at your neck just to make sure I'm not seeing any abnormals. Skin looks good, no bluing or anything like that. I don't see any actual abnormal pulsations or anything like that. If you were to lay down at less than flat, I sometimes could see your pulse in your jugular veins and everything up here. But when you're at a 45-degree angle or sitting up, I should not be able to see that. If I did, there was probably some underlying pathology that's going on that we would need to find out about, okay? But I don't see that today, so that's wonderful.
Yes, it is.
Yes, it is. Is it all right if I listen to your neck?
Sure.
And when we do this, we need the room to be relatively quiet, because sometimes the sounds that we're listening for are very faint. All right, so I'm going to go ahead and listen. Great, I didn't hear anything. What I'm really looking for or listening for are things called bruits. With bruits, it's kind of like an abnormal, thrilly sound in your neck. And I don't want to hear that, and I did not, so that's good. A lot of times the bruit will be confused with breath sounds with some people. Mm-hmm. So if I had heard something, I would have asked you to hold your breath. That way I can make sure that it is not your actual tracheal breathing sound that I'm hearing, as opposed to an actual thrill sound going in your carotids. And I did not hear anything like that, okay?
Okay.
The next, as I was palpating your neck, I did check to see if you were tender. We didn't note any tenderness.
No.
I didn't feel any masses or abnormal pulsations, anything like that. Also, when we palpate on the neck, we never want to do both sides at the exact same time. We don't want to restrict any blood flow to the brain by mashing on both carotids at the same time. Next, I'm going to look at your skin. Normally during an examination, the patient would be in a gown, but for our purposes here at Winston-Salem State University and this video, we are to stay fully clothed. And I would inspect all of his skin. I would also check his legs and his feet for any swelling, abnormal vein issues or anything like that going on. While I look at him, I also want to make sure that I'm not seeing any lesion or any abnormal bruising, just to make sure that nothing like that is happening. Also, when I check the skin, I also want to see if it might be warm and moist. If it was, that is leading me toward vasodilation, whereas if the skin was cool and clammy, that is leading me more toward vasoconstriction. Also, I would check to make sure if he had any flushing going on. Flushing could come from medicines, it could come from excessive heat, it could come from anxiety or fear. Now, I do see in your chart that you are taking niacin.
Yes.
Do you ever experience any flushing with that?
I have before.
All right, then that could be one of the reasons why you flush. And most of the time it does happen at night, right?
It does.
All right, well, good. That is good to find out. Also, with looking at the skin, we also want to look for dependent rudor or redness that comes from being a sign of arterial insufficiency. And we do not have any of that going on here today.
Good.
Also, now we are getting to the point where I need to take your blood pressure.
Okay.
All right, let me go get the blood pressure cuff.
All right.
A lot of times when we get ready to do blood pressures, we immediately want to jump into that when our patients come to see us here in the office, but they've usually had to come up from the car, they've been walking a lot, been exercising, so that is going to raise their heart rate and their blood pressure. So we want to wait until, you know, everything is back to our normal end before we get to doing our blood pressures and everything. Your blood pressure today was 116/72.
Good.
Very good. I'm going to check your heart rate. Your heart rate's about 82 at this point, okay? So all of those are very good. One thing that we will need to look for, since you are here with us in cardiac, that we do want to keep track of your blood pressures. So when you're at home, I would like for you to keep a diary of your blood pressures. I don't want you to obsess about it, but you can do it, since you're in really very good health, maybe 2 to 3 times a week, all right? And I would like for you to take it 1 hour after you take your blood pressure medicine, okay?
All right.
Now when we're doing blood pressures, normal blood pressure is different for everybody, but the way the textbook reads for normal, 120/80 is normal. When you get into pre-hypertension, the systolic pressures are anywhere from 120 to 139, or the diastolic pressures are anywhere from 80 to 89. We also can lead into stage 1 hypertension, where the numbers systolically run 140/59, or diastolically they run from 90 to 99. Or we can go into the next stage, which is stage 2 hypertension, where the number the systolic would be greater than 160, or the diastolic would be greater than 100. So as you do your blood pressures at home, do keep this in mind, but like I said, don't obsess about it, okay? Because as we have a tendency, we like to do them and we like to know what those numbers are, so let's just keep that in mind.
All right.
Next we would move on to palpating the pulses. We would palpate the radial. We could do brachial. We would do the femoral, the popliteal, the dorsalis pedis, and the posterior tibial. But for our purposes today, we're only going to check these two. All right. Now, one of the other things that I want to do that we are limited with is that I would check his chest area. I would be looking for symmetry to make sure everything was fine, that I'm not noticing any visible pulsations. With some people, the apical pulse is, the apex is visible, and the majority of most people it is not visible. But it's usually found around the 4th or 5th intercostal space. But is it all right if I listen to your heart?
Sure.
Everything sounds really good. When we are checking the heart sounds, we usually want to start up at the top where the aortic is, and then we want to move over to the pulmonic, then the tricuspid, then the mitral, and then the apex. What I'm listening for when I'm listening to your sounds is the lub-dub sound. The lub and the dub are the S1 and S2 sounds. And that's what we normally hear. Sometimes we can hear some abnormal sounds, such as an S3 sound, and it is produced by a rapid filling of the ventricles during diastole, and it's called a ventricular gallop. And it would sound like a lub-dub-ta, lub-dub-ta, lub-dub-ta. Or some people call it Kentucky, Kentucky, that kind of sound. I don't know if you ever heard anybody talk about those before. But then there's another one that's called an S4. And with the S4, it is heard in late diastole right before the S1 should happen. And it is indicative of ventricular resistance to atrial filling, and they call that an atrial gallop. And it's going to sound like talubda, talubda, or Tennessee, Tennessee. And those are some of the things that we want to hear. With an S4, it does happen a lot more with older adults, older than we are. And you hear it more at the apex, and it could be caused by coronary artery disease. It could be caused by hypertension. It could be caused by cardiomyopathies or aortic stenosis. All right, whereas the S3 could come from being pregnant, but you don't have to worry about that. Could come in children. It could come from adults less than 30. It can also come from anxiety. When we listen through here, we can also try to listen for things called a pericardial friction rub. And what that is, it's best heard at the tricuspid or at the xiphoid process. And this occurs when the pericardial surfaces around the heart seem to rub together. They would be a high-pitched grating sound. And I did not hear that today, but that would be indicative of a pericardial friction rub. Now, we also have the pleural cavity up here where our lungs are sitting, and sometimes we can get a pleural friction rub. And sometimes it is hard to differentiate between a pericardial friction rub or a pleural friction rub. And if I were to have you hold your breath while I was listening, the pericardial friction rub would continue and the pleural friction rub would stop. I wouldn't be able to hear anything. So that would tell me that it's not pericarditis or anything like that. Also, when we listen to the heart sounds, we also want to listen for things called murmurs. And with a murmur, we want to be able to tell about the timing of the murmur, the anatomical position of the murmur, where is it exactly located. And we want to document all these things in his chart. We also want to know the frequency of the murmur. Does it radiate? What is the quality of the murmur and its intensity? We also want to be able to grade the murmurs, being it from 1 to a 6. 1 is very faint, you can hardly hear it. And 6 is when you use the stethoscope, you don't even have to be on the skin to be able to hear it. Now at this point in time, during an examination, I would do an actual EKG, a 12 lead, to where I could be able to tell what his heart rhythm is. But for our purposes, in order to keep him closed, we will not do one. But that is what we do when we do a cardiac assessment. And I do appreciate your time and your effort, Mr. Davis. Thank you for letting me help.
You're welcome.
And that's it.